Wilson disease, also called hepatolenticular degeneration, is caused by autosomal recessive mutation in a gene which encodes a copper-transporting protein. This gene is called ATP7B gene, and this gene is located on chromosome 13. With mutation, gene stops working, and as a result, we cannot produce copper-transporting protein. In normal condition, this protein provides binding of copper to upper ceruloplasmin with formation of ceruloplasmin, and after we can excrete copper in form of ceruloplasmin from the liver tissue. But with defect in copper transporting protein, we cannot produce ceruloplasmin, and as a result, we cannot take away copper from the liver tissue. So this will cause progressive accumulation of copper in the liver tissue, which will cause severe liver injury. And to explain all these features, we have to know the pathway of copper in our body. So, when we consume some copper with diet, copper comes into the small intestine, where copper undergoes reabsorption. This reabsorption is provided by a specific protein called ATP7A. Once copper is reabsorbed, albumin immediately binds to copper with formation of albumin-copper transporting complex, and in this form, albumin delivers copper to liver tissue, and liver tissue serves as a storage site of copper in our organism. But copper is the essential microelement not only for liver tissue. Other tissues also require copper for their metabolism. So to deliver copper to peripheral tissues, liver packs copper into transporting protein called upper ceruloplasmin, and this results in formation of ceruloplasmin. Ceruloplasmin is basically upper ceruloplasmin fully packed with copper, and this packing of copper is provided by ATP7B protein, which is also called copper ATPase. Once ceruloplasmin is formed, this molecule leaves liver tissue, and through the bloodstream, ceruloplasmin delivers copper to peripheral tissues. Why tissues need copper? First of all, copper is a cofactor of lysyl oxidase, and lysyl oxidase is a crucial enzyme for collagen production. Also, copper is a cofactor of tyrosinase, which is a crucial enzyme in melanin production. Copper is an essential cofactor for cytochrome C oxidase, and we need cytochrome C oxidase to produce ATP in electron transport chain. And last but not least, copper is a cofactor of superoxide dismutase, which is one of the major antioxidants in our organism. So we need copper for elimination of reactive oxygen species. But in Wilson disease, mutation occurs which disrupts the production of ATP7B transporting protein. And this creates a huge problem because if ATP7B is not working properly, we cannot bind copper to upper ceruloplasmin. So ceruloplasmin production will decrease, and obviously with decrease in ceruloplasmin production, the level of ceruloplasmin in the blood will decrease. But also, with decrease in ceruloplasmin production, the transportation of copper out of the liver tissue decrease. So copper begin to progressively accumulate in the liver tissue. And I think you already noticed one interesting thing about the copper. Once copper comes to our organism, copper practically never walks alone. And it's not because copper is Liverpool fan. The reason is that free copper is a lighter, and water combined with oxygen is a gasoline. And as you know, we have a lot of water and oxygen in our body. The problem here is that copper in a free state reacts with hydrogen peroxide, and we know that hydrogen peroxide is formed from water and oxygen. This reaction we call Fenton-like reaction, and as we see, the final products of this reaction are hydroxyl radicals. Hydroxyl radicals belong to reactive oxygen species, which means that they are extremely dangerous substances. And accumulation of free copper in the liver results in massive production of hydroxyl radicals that cause severe oxidative stress in the liver tissue. Oxidative stress leads to a severe liver injury, so initially hepatitis develops. With liver injury, hepatocytes die and their internal content begin to leak into the blood. So death of hepatocytes will cause increase in ALT level, increase in AST level. Also bilirubin level will increase. Increase in bilirubin level will cause jaundice, and also this massive amount of accumulated copper that was stored inside the hepatocytes will finally enter into the blood, which will cause increase in free copper level in the blood. The problem is that it's a free copper, and we know that copper should never walk alone. These free copper molecules will income to the most metabolically active tissues. First of all, it's CNS, because free copper can cross blood-brain barrier. In the CNS, progressive deposition of copper can cause neurologic or psychiatric disease. Usually, CNS injury manifests as dysarthria, dystonia, tremor, or as Parkinsonism. Also, free copper likes eyes. More precisely, free copper begin to deposit in the descendant membrane of the cornea, which will result in formation of Kayser-Fleischer rings. Also, copper begin to deposit in the kidney tissue, which can cause Fanconi syndrome or kidney stones. And last but not least, copper begin to deposit in the joints, which will cause arthropathies. But there is another problem. With decrease in ceruloplasmin production, the delivery of copper to peripheral tissues decrease. And one of the functions of copper is to serve as a cofactor for superoxide dismutase. So without copper, superoxide dismutase does not work, which means that we cannot eliminate free radicals. And accumulation of free radicals causes severe oxidative stress in tissues. And one of the most vulnerable cells to oxidative stress are red blood cells. And severe oxidative stress inside the red blood cells causes their destruction. This state we call hemolytic anemia. Here we can see the most recent guideline on Wilson disease. And because liver injury is the most significant feature of Wilson disease, let's discuss the most common clinical manifestations of liver injury. First of all, Wilson disease can cause jaundice, anorexia, and vomiting. The reason is that with liver injury, hepatocytes die, and bilirubin molecules that were contained inside the hepatocytes enter into the blood. Also, liver detoxification function decreases, which means that bilirubin conjugation will decrease, and conversion of ammonia to urea decrease. As a result, blood urea level drops, while free ammonia level rise, and increase in free ammonia level will cause hepatic encephalopathy, anorexia, and vomiting. The second symptom is ascites or edema. The reason is that with liver injury, the production of albumins decrease, and decrease in albumins level will cause decrease in oncotic pressure, which will cause edema and ascites. But there is also the second reason why ascites develops. As we see, Wilson disease frequently manifests with variceal hemorrhages and with hepatosplenomegaly. All these symptoms are related to portal hypertension. The reason is that chronic liver injury causes massive fibrosis in the liver tissue, and fibrous tissue will cause compression of liver capillaries that in turn will cause accumulation of blood in the portal vein. And the more blood accumulates, the higher becomes the pressure inside the portal vein. And portal hypertension causes formation of portosystemic shunts, which leads to a formation of esophageal varices. And we know that at some point it can be complicated by variceal hemorrhages. Also, it causes formation of caput medusa, and it causes formation of hemorrhoids. In addition to this, portal hypertension with time will cause accumulation of blood in the liver and in the spleen, which will cause hepatomegaly and splenomegaly. The next symptom is hemorrhagic diathesis. The reason why hemorrhagic complications can develop is that with liver injury, thrombopoietin production decrease, which will cause decrease in platelet count, and decrease in platelet count cause disruption of primary hemostasis, which typically manifest with bleeding from mucous membranes or microhemorrhages. Also, with liver injury, the production of coagulation factors decrease, and decrease in coagulation factors will cause disruption of secondary hemostasis, which will manifest with prolongation of PTT, PT, and INR. Hemolysis is also a common symptom. We know that hemolysis occurs due to the decrease in copper delivery to peripheral tissues. This will disrupt antioxidant system, and thereby it will provoke oxidative injury. And red blood cells are one of the most susceptible cells to oxidative injury. In some cases, Wilson disease can even cause acute liver failure, where all these symptoms will present in a more severe way. And sometimes this disorder at time of diagnosis could remain asymptomatic. So here we see a real blood analysis of a patient with Wilson disease. Hemoglobin level is 95, which we classify as moderate anemia, and most probably anemia developed due to the hemolysis. Blood bilirubin level is elevated, which at some point will cause jaundice. We know that elevation of bilirubin is caused by leakage of bilirubin from damaged hepatocytes, and also due to the hemolysis of red blood cells. ALT, AST, and alkaline phosphatase are elevated. Elevation of liver enzymes caused by leakage of enzymes from damaged hepatocytes. Platelets still normal, but PT, INR, and PTT are all prolonged. And the reason is that with liver injury, the production of coagulation factors decrease. So, how to diagnose Wilson disease? First of all, we diagnose Wilson disease by decreasing serum ceruloplasmin level, because with defective ATP7B protein, liver cannot produce ceruloplasmin. Also, we can determine increase in 24-hour urinary copper test and increase in serum free copper level. The reason is that we know that with death of hepatocytes, huge amount of free copper enters into the blood, and free copper we excrete by the urine. On liver biopsy, we can determine increase in hepatic copper, which is absolutely logical because in Wilson disease, copper progressively accumulates in the liver tissue. And on physical examination, we can determine Kayser-Fleischer rings, which is the signature feature of Wilson disease. And nowadays, we have a scoring system. Basically, the higher the score, the more likely it's Wilson disease. So, which features tell us about Wilson disease? First of all, it's Kayser-Fleischer rings, neurological symptoms, and increase in liver copper level. All these features are caused by deposition of free copper in the tissues. Also, we have laboratory markers as decrease in serum ceruloplasmin level and increase in urinary copper excretion. And we know that the higher the copper level in the blood, the higher will be the copper excretion into the urine. If person has hemolytic anemia, Coombs test should be negative. This will tell us that there are no autoantibodies against own red blood cells. So this anemia developed not due to the autoimmune aggression. And also, we can determine the mutation itself that caused defect in ATP7B protein. So obviously, the presence of this mutation will tell us that it's Wilson disease. So let's summarize. With defect in copper transporting protein, the production of ceruloplasmin decrease, which will cause progressive accumulation of copper in the liver tissue. With time, hepatocytes will die due to the copper-induced liver injury, and free copper will leak into the blood. And from the blood, copper will go into the all metabolically active tissues. is brain tissue, cornea, and kidneys. And because there will be so much free copper in the blood, urinary copper excretion will be also increased. Wilson disease usually affects people before the age 40 and typically presents itself with liver disease as hepatitis or cirrhosis. But then, on physical examination, you will find out that patient has neurological symptoms or psychiatric symptoms, Kayser-Fleischer or hemolytic anemia or renal disease. And when you have several of these features combined, you can think of Wilson disease. And among all these features, deposition of copper in the cornea is the most signature feature. The logic in treatment is to eliminate free copper by chelation, and to do this we prescribe penicillamine or trientine or oral zinc. All these substances can bind to free copper with formation of a stable complex, so they can neutralize free copper. And if Wilson disease presents with acute liver failure, liver transplantation is the only option.